I'm going to go over some of the findings for portal hypertension. So for this presentation, we're going to go over some of the normal waveforms, again, just recognizing what we look for in our routine exams so that we can identify pathologies, go over what we expect to see with portal and hepatic vein thrombosis, review the findings for portal hypertension, and finish up with a discussion about tips. As we get more and more dependent upon our sonographers to show us these findings, I think it's really important to spend the time with them to review the anatomy and some of the tips and tricks to find these vessels and to let them know what we're looking for. One of the ways I do that is by sharing some of the CT and MR images on these patients to show them where the pathologies might be and where they should be looking. Certainly their scanning skills are superior to most of us, but at the same time, we have to sort of give them an idea of what we're looking for so that they can produce those images that show us the abnormalities. So reviewing the portal system and the potential areas for collateral flow, I think is really important. One of the things, of course, that they should be very familiar with is the different type of flow patterns that we see in both the portal and hepatic veins. And when I think about the portal system, we recognize that it has relatively low velocity flow in one direction, very similar to what we see in the lower extremity venous system. And that's a nice analogy for them because because they're used to doing lower extremity venous studies, if you tell them the portal system is very much like the femoral veins, low velocity, unidirectional toward the liver, they get that. And also by explaining to him that the IVC and the hepatic veins are more pulsatile. We typically see flow above and below the baseline, and that flow pattern is similar to what we see in the upper extremity veins because they're closer to the heart. That's also helpful for them to remember what those normal flow signals are. We all know that the portal vein provides most of the blood flow to the liver, about 70–75%. The rest is provided by the hepatic artery, which is why when you have portal hypertension or thrombosis of the portal vein, that the hepatic artery becomes hypertrophied. We see it and typically will develop that corkscrew appearance when we scan it. Hepatic artery should be readily seen on most of our studies, although something we may not be thinking about in terms of the evaluation of portal hypertension. We will see increased flow. We will see increased tortuosity. And the waveform is very similar to what we would expect to see with any artery that supplies a low resistance organ. Whether it's the brain, the liver, the spleen, the kidney, they all have a very similar flow pattern. And we'll talk about this a little bit more later this morning when we talk about evaluation of the renal and mesenteric arteries. And when you have that low resistance organ that demands continuous forward blood flow, like the brain, the kidney, or the liver, you have a rapid systolic upstroke and lots of continuous forward flow throughout diastole. So we'd expect to see that very low resistance flow pattern. What you may be able to see once in a while is a complication that may be related to a procedure. Here was a 68-year-old that had biliary drainage in a patient with pancreatic carcinoma, and we saw this sort of abnormality on our examination of the liver. Here we see this cystic lesion adjacent to the hepatic artery and portal vein. When we sample around it, and you can see here we're scanning along the periphery of that cyst, where we see a little bit of blood flow, we get this very unusual to and fro pattern. And for those of you who typically will scan these groin masses after procedures, we typically look for pseudoaneurysms, and the way we distinguish a pseudoaneurysm from an arteriovenous fistula after a femoral cath is by looking at the waveform, right? With a pseudoaneurysm, you have that to and fro flow because there's a change in the pressure gradient. Blood flow goes into the pseudoaneurysm in systole, and then there's reversal below the baseline during diastole. And so when you see to and fro and sort of that cystic kind of mass in the groin, you do think pseudoaneurysm. In this particular case, what we have is a hepatic artery pseudoaneurysm that was a complication of the procedure. Again, in this particular example, we don't see it filling the cystic space, but we do see flow around the periphery that allows us to make that diagnosis of pseudoaneurysm. So So when we evaluate the portal system, obviously that includes the splenic and the mesenteric veins, and no matter where we sample in the portal system, we should have that same low velocity undulating pattern. We say it's variable pulsatility, but relatively low velocity. And that blood flow should be in one direction, toward the liver. Shouldn't be reversed, shouldn't be biphasic, one direction. But it should maintain that change in velocity over time, what we call phasicity. Again, very much like when we evaluate the lower extremity veins. We don't expect the waveform to be flat. We expect a change in velocity over time related to cardiac contractility and changes in intra-abdominal pressure, which change the size of the vessels, which gives us the change in velocity. That allows us to say that the proximal veins are patent. The IVC is patent, the iliac veins are patent, when we look for that phasicity. If it's flat in the lower extremity veins, we know that there's some proximal obstruction. And when we evaluate for portal hypertension, if the veins are flat, that means there's obstruction to the portal system. It's the same concept. So the flow, as I said, similar to the lower extremity veins. So we recognize that the size of the portal vein changes after eating, deep inspiration, and Valsalva. It also changes in position and in the fasting state and following exercise. It increases after eating, decreases with fasting. If you take a deep breath and hold it, again, it changes intra-abdominal pressure. You can lose some of the phasicity, why it's better to evaluate it without a deep inspiration. And we recognize that the normal size of the portal vein is typically less than 13 millimeters. When it's greater than 1.5 centimeters, we start thinking that it's dilated. Normal velocity range is about 10 to 20 centimeters per second. It's a pretty low velocity flow normally in the portal vein. Now, if we do see changes in the waveform shape, particularly increased pulsatility, sometimes we start thinking about fistula or abnormal communications. But most commonly, when we see increased pulsatility in the portal system, it's related to cardiac effects. And we should be thinking about tricuspid regurgitation and congestive heart failure. Those are the most common reasons to be seeing these changes of increased pulsatility, particularly when you start to see that biphasic pattern, okay? And with reversal, think about cardiac disease. Another abnormality you might pick up in the portal system is gas. On the grayscale image, you will see those little echoes sort of coursing through the portal system. And if you're seeing echoes in the portal system, you have to be concerned that there is evidence of portal venous gas. What's interesting, if you do the Doppler evaluation, that you will not only see the underlying portal flow, but you'll see spikes, artifacts, when the Doppler beam hits the gas bubbles. And those spikes are very consistent and representative of bubbles in the portal system. Now, of course, looking for thrombosis in the portal vein is like looking for thrombus in any venous system. You're going to see distension acutely. You're going to see low-level echoes within the vein. With healing and over time, you'll get recanalization, irregularity of the lumen, and of course, changes involving the parenchyma. The liver acutely will be swollen, maybe enlarged, and you'll see some heterogeneity. And if it produces the full-blown portal hypertension, then we'll start to see some of those other findings we'll talk about in just a minute. In the Doppler examination, if you have thrombosis of the portal system, you will get dampening of the waveforms downstream. You'll get flattening. You'll lose the phasicity. Sometimes with severe portal hypertension, you will actually see reversal of flow. And that's one of the signs that we can grade portal hypertension as being severe, is that flow is going away from the liver. And in that situation, you certainly will see evidence of collateral flow. Obviously, in the thrombose segment, there'll be absence of color Doppler signal. Here's an example of thrombus in the portal system. This may be related to a number of different etiologies. It could be related to tumor, such as hepatoma, trauma, inflammatory diseases, Crohn's disease, inflammatory bowel disease, hypercoagulable states, or cirrhosis. Again, expect to see changes in the size of the liver and spleen. Acutely, the liver gets enlarged. And then obviously with portal hypertension, increased portal pressures, you'll also see enlargement of the spleen. We may see the presence of collaterals, particularly if we look for them. And in some cases, patients may develop cavernous transformation. And that's essentially replacement of the portal vein by these small collaterals. Here's an example of a patient that presents on acute portal vein thrombosis. Again, looking at the different modalities, I think is very important to compare the appearance. On contrast-enhanced CT, again, you see a defect, lack of contrast enhancement of the portal veins, particularly inside the liver. Similar appearance with contrast-enhanced MR, where we see lack of enhancement, and with a color Doppler ultrasound, you'll see the filling defect. Internal echoes within the portal vein may see collateral flow and flow around it, particularly enlargement of that hepatic artery. One of the things that we may do now if we're having trouble looking at the portal vein is some maneuvers we'll talk about in a second, and contrast-enhanced ultrasound has also been suggested to help with problem cases. Now, many years ago, Franklin Tessa described the use of color Doppler in the evaluation of portal vein thrombosis. And even back then, when you go back a few decades, you can see that it still had pretty good sensitivity and specificity. And certainly the improvement in our color sensitivity now allows us to be fairly certain when there is flow in the portal vein. So if you see flow, if it's negative for portal vein thrombosis, you're done. There's no need to confirm that. The issue does come up, though, if you don't see flow, because color Doppler has limits to sensitivity. And so if you don't see flow in the portal vein, then you have to question, is it very slow flow, and it's just a limitation of the study, or is it really thrombosed? Now, there's a couple of ways to sort that out. Obviously, you want to optimize the study. You want to make sure your gain is optimized. You want to make sure your PRF is low. Your wall filter is low. You can use color Doppler and some physical techniques as well to make sure. And certainly look for echoes. I mean, if you see echoes within the portal vein, that certainly suggests thrombosis. So to work through this slow flow pitfall, here's an example here. If you look at the image, you can see that the arrow is pointed to the portal vein. We don't see any flow in it. We do see flow, though, in the adjacent hepatic artery. So it makes it suspicious for portal vein thrombosis. And certainly in a patient that's sent to you with liver function abnormalities, and it's to rule out portal thrombosis, an image like this will make you extremely suspicious and make you likely to call that and make that diagnosis. So these are the things to think about. But one of the things I found really helpful, and has helped me in some cases, in just compressing on the abdomen. It's an augmentation technique. Just like when we squeeze the leg to improve flow in the lower extremity veins when we don't see it, it works the same way. You're pushing on the portal system. It brings blood flow back into the main portal vein and allows you to see it, as we do in this case. So just a simple compression or augmentation technique can be very helpful. You can also have the patient do a Valsalva, which may also increase venous return, and you'll also get increased flow after a meal. But the easiest and the quickest thing to do in these situations is just compress the abdomen. So if the sonographer comes to you and says, I think it's thrombose, make sure that they compress the abdomen so that you can see if there's flow there or not. And here's just another example. This exam comes through, they put color Doppler on, you see, well, there's some flow, but there's this area here that doesn't fill out. Press on the abdomen, and you can see that the vessel completely fills in. And so you've now proven that the patient does not have portal vein thrombosis. Many times, grayscale is extremely helpful. In fact, I insist on grayscale in addition to color because I want to see if there's low-level echoes, if there's a partially occlusive thrombus there. Here's color Doppler, again, very helpful. It outlines the thrombus inside the portal vein. So we liberally will use color and switch on and off with power. Again, having that ability because of the increased sensitivity to flow can give you a very powerful image. Here's another example here where you see what looks like some thrombus in the portal vein, but actually when you turn it on, it's actually completely thrombosed. And this may be a case of acute on chronic thrombus. It's hard to tell sometimes when you have different echogenicities, but certainly we weren't able to demonstrate any flow in the portal vein. And sometimes we can just see areas that are not completely recanalized. Here's a patient that has a history of inflammatory bowel disease, had colectomy, and we're assessing for portal vein thrombosis because of the liver function abnormalities. And you can see here there's residual thrombus in the portal vein. The color Doppler showing it very well. The pitfall here, of course, is not to have the color gain set too high, because color can override grayscale. And as I'll show you tomorrow at the SamSlam course, I'll show you some of the pitfalls of vascular imaging where clot can be obscured by color flow imaging. Here's a 45-year-old male, history of HCC. And we have thrombus in the superior mesenteric vein extending into the portal vein. And what we notice is that there's flow inside that thrombus. So it's very interesting. So this is clearly an example of tumor thrombus when we see increased flow within the clot. Here's a power Doppler image again. This is the area of the portal vein here. And you can see there are tiny vessels there, and when we sample those vessels, we get very low resistance arterialized flow, classic for tumor vascularity. You know, tumor vessels are abnormal, they have very thin walls, poor muscle within them, and what that translates to on the Doppler exam is relatively high velocity, low resistance flow in tumor vessels, demonstrated in tumor thrombus. Another example here in a patient clearly with cirrhosis. You can see the nodularity of the liver contour, increased echogenicity of the liver, lots of ascites, arrows pointing to the portal vein, and you can see it's completely thrombosed. The natural history for portal vein thrombosis, it can organize, stay thrombosed, and have collateral vessels, bringing blood flow around the thrombosed segment back to the liver. You can have recanalization, which can be partial or complete. And of course, as I mentioned earlier, cavernous transformation of the portal vein. So here's an example of a patient that presented with liver function problems. Where's the portal vein? This is the area of the porta hepatis, and we see a lot of these little tubular structures, little cystic areas within the portal bed in the region of the porta hepatis. You can see here is the IVC. And you're saying, well, the portal vein should be in there. We put color on, and basically what we see is a lot of these tortuous little vessels. So this is a classic example of cavernous transformation where we don't see a normal portal vein, just a lot of collaterals that are seeding through the portal bed. So again, cavernous transformation, as you know, results from portal vein thrombosis. You could see it readily on your CT and MR as well as on your ultrasound. On this color Doppler image, you can see it sort of has a spiral pattern. It looks like twisted vessels because there's so many in that little space. You basically get this complex collateral network, which replaces the portal vein and presents as a mass of tortuous vessels. And if you sample them, you will see low velocity venous signals, which would help you to distinguish it from tumor thrombus. Because you might say, well, how do I know these aren't tumor signals? These are venous signals as opposed to the arterialized signals we see with tumor thrombus. This is a 52-year-old male with a history of metastatic disease, unknown primary, and clear from this example, you can see evidence of metastatic disease here, as well as all these little tortuous vessels in the porta hepatis, another example of cavernous transformation. So key points to remember when you do the portal vein exam is that normally portal vein is phasic, it's unidirectional, similar to lower extremity veins. Portal vein thrombosis may organize, recanalize, or produce a cavernous transformation. And if you see increased pulsatility in it, whether it's in one direction or it becomes biphasic, think about cardiac problems such as tricuspid regurg and CHF. Now, moving on to the hepatic veins and IVC, we already mentioned that the flow pattern is very different. Rather than having that unidirectional undulating pattern, here we typically see a more pulsatile pattern, typically bidirectional, where blood flow is predominantly away from the liver, obviously toward the heart, but we have that regurgitation that occurs with atrial contraction. So we say it's hepatofugal, away from the liver, the pulsatility related to cardiac contraction, and flow will go toward the heart during ventricular systole. And we get reversal of flow during atrial systole. And we can break it down very simply by looking at this W pattern. This is the normal configuration of the waveforms we see from the hepatic veins and the IVC. Pulsatile, triphasic, reflecting right atrial pressure. That longer initial component, that S wave, is related to filling of the right atrium in systole. As it continues to fill, it slows down. You can see that the velocity in the V wave is definitely slowing. And then when there's continued filling of the right atrium in diastole, we have continued velocity away from the liver toward the heart. And then when the atrium contracts, then you have that reversal of flow back toward the liver, the A wave. Now that's the normal appearance. Sometimes the appearance is abnormal and it looks more like a sine wave, where the amplitude of the reverse flow component may be as great as the component going toward the heart. And when you see that increased A wave, then you think about congestive heart failure. Again, increased pulsatility back toward the liver. That sine wave appearing waveform is consistent with CHF. And we make this diagnosis and impress our cardiologists by telling them that's what we see on our exam. Now, when we have thrombosis of the hepatic veins in the IVC, we typically call this Budd-Chiari, and this can be related to extension of lower extremity DVT. It can be less commonly due to a congenital web. Those are things that we typically don't see, but we see abnormal flow in the IVC and the hepatic veins. So when we see that, the web can be difficult to identify. I have one case where I was really able to see the web well. Sometimes they'll go on to the IR guys and they'll do a venogram, and at the same time, they can strip the web when they find it. We also see it related to trauma, underlying malignancy, such as HCC or a renal cell, and obviously can be due to hypercoagulable states. Now, as similar to what we would see with portal vein thrombosis, where you lose the phasicity, when you have obstruction of the IVC and the hepatic veins, we lose that pulsatility. And again, you get more like a flat, continuous looking flow pattern, as we do here in this patient that has IVC thrombosis. Another thing you can see with Budd-Chiari are these abnormal communications between the hepatic veins and the portal veins, and you'll see these unusual collaterals. And when, again, scanning through, you can pick them up if you look for them. And then again, another sign that you have a venous abnormality when you see the intraparenchymal or subcapsular collaterals that communicate between the hepatic veins and the portal veins. Here's an example of a patient that has this partially occlusive thrombus just sitting in the IVC. And this is the kind of patient I very gingerly walked away from because I didn't want to dislodge it and necessarily cause a pulmonary embolism. And of course, I'm sure the patient was having some PEs that were occurring, but this looked like a relatively larger clot. And we could see that it wasn't completely occlusive as we can see flow that's around it. So it was just sort of sitting there. And so we realized the patient needed to really get back to their room and be set up with some anticoagulation. And as we sampled the patent portion of the vein, again, it's lost its pulsatility. It doesn't look like a W shape. It's relatively flat because of the obstruction to flow. So here's a case of IVC thrombosis, but again, not completely thrombosed. One thing we get asked to look at from time to time is patency of an IVC filter. Certainly, if they're considering removing the filter, they want to make sure it's not thrombosed. In this particular case, they were concerned about the placement of the filter. They thought it was above the level of the renal veins, and it was. And again, before changing its position, they wanted to make sure that there was no clot there. And here on the grayscale image, it's easy to see the filter. It's relatively echogenic. You can see the struts in the wall of the IVC pretty readily. Again, look at that grayscale image first. Turn the color on, show that there's flow going through the IVC. You check the waveforms. There's no evidence of any obstruction. No thrombus was seen. Which you can contrast with this case in a patient that had continuous leg swelling, history of DVT, and IVC filter placement. And in this case, you can see the filter on the grayscale. Here are the outstretched arms of the filter, and you can see that the IVC below it is distended. It's packed with clot. You can see the echoes from the thrombus, and it was thrombosed below down to the level of the iliacs. And here's the color Doppler image, again, showing flow above the filter. The renal veins were patent. That's where the blood flow is coming from the renal veins, but you could see below the filter it was completely thrombosed. So things to remember for the hepatic vein and IVC examination: flow is normally pulsatile. We get reversal of flow during atrial systole back toward the liver. When you have this sine wave pattern, these are enlarged A waves associated with congestive heart failure. And when you have this sort of dampened monophasic pattern, think about proximal obstruction of the veins. Okay, in terms of portal hypertension, we know the level of obstruction can be at different levels. It could be before the liver, such as when there's thrombosis of the portal vein. Intrahepatic portal hypertension is obviously related to problem within the parenchyma itself. It could be pre-sinusoidal, related to schistosomiasis, sinusoidal, what we see with cirrhosis. Or we can have posthepatic portal hypertension related to obstruction. Blood flow can't get out, which is what you see with Budd-Chiari. Some other veno-occlusive diseases, an IVC web, or possibly constrictive pericarditis. Less commonly, you can have portal hypertension related to a hyperdynamic state, which could be seen with a fistula. Now, when you have portal hypertension, we all know it's related to obstruction, increased resistance to flow through the liver, through the portal system. We'll see increased flow in the splanchnic veins, and you'll develop a number of different portal systemic collaterals. Again, important to share these with your sonographers to make sure that they're looking around the stomach, look in the abdomen, particularly around the umbilicus, and you can see a lot of these different collaterals. Anywhere there's branches to the portal system, there's the possibility of developing collaterals from portal hypertension. One of the things that you'll see, again, with severe portal hypertension is reversal of flow in the portal vein. And these are some of the findings that we ask our sonographers to look for. Enlargement of the portal vein, obviously patency of the portal vein, looking for varices or these collaterals around the porta hepatis and around the different branches. We expect to see some element of hepatic parenchymal disease, certainly with cirrhosis. And with cirrhosis, obviously looking for evidence of tumor within the liver. The spleen is usually enlarged, typically in the later stages. There's associated ascites and portosystemic shunts, of which the parambilical vein is the most specific sign. And that's important to remember for when we go over questions in a few minutes. Portal vein, again, we said that normal size is less than 1.5 centimeters. If it's greater than 1.5, we say it's enlarged. Other things to look for is the direction of flow and the phasicity. Loss of respiratory variation, again, speaks to obstruction. It speaks to portal hypertension. And the velocity tends to decrease when there is portal hypertension. Here's an example on contrast-enhanced CT of an enlargement of the portal vein. And here it is on the coronal contrast-enhanced MR. Again, both of these, the measurement is greater than 1.5 centimeters. Again, just another look at the collateral pathways. These are all areas where you can identify collateral flow. And you can see most of these if you look for them. Certainly looking around the stomach, as I'll show you in a minute, you'll see gastroesophageal varices. A recanalized umbilical vein, not hard to find when you're scanning through the liver. And you can scan through the left lobe, you can see it coming off in the falciform ligament. You certainly, when you're evaluating the spleen, identify the splenic or splenorenal collaterals. And the other ones, more difficult to find, but if you look for them, you will see them on your exam. Here on CT, you identify them in the typical location around the stomach. You can see these enlarged gastroesophageal varices. On ultrasound, the key is to scan around the left lobe. The left lobe is your window to that cardiac area of the stomach, and you can pick up the varices. And here they are on angiography. Again, left lobe is the key. Scanning around there, you can pick up some of these varices that are arising from the stomach, which is outlined with those arrows. You can see enlargement of the coronary vein, again, similar location. You could identify it above the level of the superior mesenteric vein. When it's greater than 7 millimeters, we say it's dilated and flow is in the reverse flow direction. Bless you. Obviously, scanning around the spleen, you'll pick these up relatively easily as the spleen serves as your window. And here we have an enlarged spleen here, and it looks like a large cyst. But when you turn the color on, of course, you can appreciate the fact that they all fill in with flow, and if you sample them, you'll get venous signals. So these are very large perisplenic varices. And sometimes you can appreciate the communication of these varices with the renal veins. So that's a very nice way for them to decompress and get the blood flow back to the systemic circulation by being able to course into the renal vein. And here you can see that both on CT and on ultrasound, these communication between the splenic vein and the renal vein. Here's a look at the paraumbilical vein, again, coursing from the left portal through the falciform ligament, and you can follow it all the way down through the abdomen and see the caput medusa, as you can appreciate when you examine the patient physically, as well as looking at the collaterals. Here's the CT following the paraumbilical vein down the anterior abdominal wall, and you can see how those branches come out into the soft tissues of the lower abdomen. And there's the communication with the external iliac vein. And here we appreciate them as they course to the soft tissues of the skin surface. And again, you can see them on physical exam and also on the Doppler exam. Okay. What I'm going to do here is go right to the evaluation of tips. Everyone recognizes that tips are placed to alleviate the increased pressures from portal hypertension. It serves as a bridge or a conduit, right, from the portal system, bypassing the liver into the hepatic vein and the IVC. When they're patent, they're typically easy to see because we can scan through the tips and see flow within the stent itself. Obviously, if it's thrombosed, we see it's filled in with low-level echoes. Indications, again, related to bleeding, and the other signs of portal hypertension, Budd-Chiari, hepatorenal syndrome. Schedules have been identified for following patients with TIPS. Typically like to do a baseline to see what the velocities are and follow it over time. We like to do it every few months. Patients are reluctant to come back for these follow-ups, but it's very helpful to find problems and stenosis before the TIPS thrombosis, because secondary patency rates are not very good. Important to remember that the normal velocity range for TIPS is 90 to 190. Very high velocity flow, something not always recognized. We'd expect to see high velocity flow in the TIPS. And the other important thing to remember about TIPS is when the TIPS is patent, blood flow in the right portal vein and left portal vein is reversed. Instead of going out toward the periphery of the liver, it's toward the tips. And those are important signs of TIPS malfunction, is look for the reversal of flow. So here's a patient post-TIPS. You can see the ascites, the cirrhosis, and we're getting our velocities, which should be between 90 and 190 centimeters per second. And we need to take samples at multiple locations, proximal, mid, and distal portion of the TIPS. When there's evidence of stenosis, which could be related to bile duct injury or just intimal hyperplasia over time, we'll see gradual narrowing before there is thrombosis of the tips. And of course, what are we looking for? We're looking for filling defect, narrowing, aliasing, and with stenosis, increased velocities in the stenosis and low velocity flow in the remainder of the tips from the obstruction. So when there is a stenosis, it's typically greater than 200 centimeters per second. And we'll see a change in the velocity in the remainder of the tips compared to the baseline. So the things we look for: narrowing on the color display, elevated velocity in the stenosis, but if you don't see the stenosis, decreased flow in the tips, and the change in the direction of flow, particularly in that left portal vein. Here's an example of a stenosis. Here the velocity is about 220 centimeters per second. We could see the narrowing and the aliasing. Here's the low velocity flow in the tips from a stenosis at the distal end. And now the velocity is decreased because of that obstruction. Here's the reversal of flow in the left portal vein. When it's functioning, flow is toward the tips. When it's obstructed, it's away from the tips, back toward the periphery of the liver. Here's a patient had worsening portal hypertension. In the distal tips, the velocity close to 300 centimeters per second, and in the proximal portion of the tips, the velocity is less than 20. Very classic. Here's an example of a thrombosed tips. So finishing up, normally high velocity flow in the tips. The rule of 50 has been proposed in that when you have low shunt velocities, less than 50, think about obstruction at the distal end. Portal vein flow should be toward a patent tips, and if it's obstructed, it's then again away. And when we do see stenosis, they're typically at the hepatic side, the distal end of the tips.